Howdy folks, today we'll be talking about EKG interpretation. Note that this will be the first video in a series of videos on this topic, as it's a very broad and complicated topic. Let's take a look at our agenda for the day. First, we'll be talking about EKG leads and their orientation with respect to the heart. Then, we'll be going over the basic algorithm for interpreting an EKG. Note that we're going to be assuming a basic familiarity with the anatomy of the heart and its electrical conduction system. If you're unfamiliar, there are plenty of other videos and resources to familiarize yourself with these concepts. In addition, in another one of my videos, I go over the basics of this, so I can link it in the description below. So a standard 12-lead EKG is comprised of two groups of 6 leads. We'll be taking a look at this first group of 6 leads that is known as the hexaxial leads. So here we have the outline of a patient with these 6 leads overlaid on them that are represented by blue and purple vectors. Now it's important to know that these 6 leads are actually information obtained from 3 electrodes that are placed on the patient's body. These 3 electrodes are drawn here as purple dots. We have one electrode drawn on the patient's right shoulder, another electrode drawn on the patient's left shoulder, and there's another electrode that's placed on the patient's left foot, where we've drawn it here just as their inferior because it's going straight down. Now, the 6 leads in this hexaxial system are lead 1, 2, 3, and leads AVR, AVL, and AVF. I'm going to start talking about each one of them. So let's take a look at lead 1 right now. Notice how this is an arrow drawn from the patient's right shoulder to their left shoulder, with the arrow facing in this direction. What that basically means is that this lead is picking up electrical activity that's going from the patient's right towards their left. So imagine my eye is the lead. I'm looking at electrical activity going from the patient's right to the left. So if a beam of electrical activity were going directly into my eye, the vector would be going directly into my lead. So it's picking up information going this way. Now, lead 2 will be looking at information going from the patient's right side downwards to their inferior side. So imagine my eye is looking directly that way. My eye is lead 2. Now for lead 3, it's sort of the opposite side. We're picking up information going from the patient's upper left side, inferior. So my eye is basically lead 3 right now. Now, the similar concept applies to leads AVR, AVL, and AVF. Even though these aren't constructed from 2 leads, they're just sort of looking at one electrode, but that distinction is not important for interpreting the EKG. So, for lead AVR, imagine I was tall enough to look at this patient's right shoulder. I'll be looking downwards towards the middle of the body. That'll be lead AVR. And for lead AVL, imagine my eye is looking downwards towards the patient's middle, going up towards my eye. That's the perspective of lead AVL. And finally, for lead AVF, imagine I was directly under the patient, looking upwards toward them. That's the perspective offered by lead AVF. So to summarize, the leads basically give you a perspective on electrical activity coming from different parts of the patient's body that are represented by these arrows. So looking down here, up here, down here, or looking from this side, or from this side. And you can kind of imagine it as eyes, if you will, that are looking at electrical activity that are going towards them. So now, let's take those 6 leads we talked about earlier and to translate them to this image here. This system is known as the hexaxial reference system. We start with the 0 degree mark here, and this angle is going to increase going clockwise and decrease going counterclockwise. Now notice how all these vectors have the same directions as the leads we talked about earlier, but they're all centered at the central point here. This is useful in thinking about because we can think of the heart as being in the middle of this diagram here, and all of these leads looking at the heart from a different perspective. So for example, lead 1 here, we're looking at the heart directly from this side. For lead AVF, we're looking at the heart directly from under the heart. And we can think about electrical activity coming from the heart in one of these directions. Now what's really important to know is that the electrical activity of the heart won't necessarily be happening directly in the direction of any one of these leads. For example, if the activity of the heart is going in this direction, lead 1 or 2 are not directly in this direction here. Rather, we have to look at the component of that vector directly in the direction of leads 1 or 2, or this is an arbitrary example, in order to actually measure the electrical activity. And we're going to do an example right now. So now, let's take a little look at our example again. We said we're going to imagine that the electrical activity of the heart is traveling in a 30-degree direction as indicated by this green line here. Now in order for the leads to analyze this vector, they're going to need to look at the component vector. So let's break up green into this component vector here that's looking directly in the direction of lead 1. Now lead 1 is going to record this component vector and write this on the EKG. And notice how this is shorter than the green vector here because it's only the component in the horizontal direction. Because of that, this isn't as high as it could be, but it's still going to be positive. Now let's compare lead 1's recording with lead AVF's recording down here. Now a similar thing, we need to break up this into its component vectors. And this is the component vector of this green vector in the downwards direction. Now note how this vector is shorter than this vector, right? Because 30 degrees is a lot closer to this line than to that line. Because of that, the recording on AVF will be shorter but still positive, because this component is shorter than that component. Now finally, let's look at what AVR would record. Because AVR is in the complete opposite direction of this vector we have here, it's going to record it as a very, very negative deflection as we see here. Now this is more negative in magnitude than either of these, because this is completely opposite in the direction. So this is basically the full length, but completely opposite direction, so it's going to be negative. So we can see here how different leads can record the same exact electrical activity of the heart in very different ways. And that's really, really important to understanding EKGs. So now, let's take a look at the second group of 6 leads, known as the precordial leads. Let's take a look at this diagram here. This is a transverse image of a patient. This is the patient's backside, and here's the spinal cord to give you reference. Here's the patient's front or anterior side, and here's the patient's sternum to give you reference. Now, V1 through V6 represent the precordial leads. These are looking at different perspectives of the patient in this transverse plane. So V1 and V2 are more anteriorly in the patient, and going towards V6, they become more lateral. So these give you a more anterior perspective, whereas V5 and V6 give you a more lateral perspective. This is important as V1 and V2 can give you more information on things that maybe relate to the septum or the right ventricle, whereas V5 and V6 can give you really good perspectives on things that are happening definitely in the left ventricle. And we're going to talk in later videos on some of these important distinctions. So let's end our discussion of EKG basics by looking at a standard waveform with an accompanying heart diagram. Now, pathological EKGs may lack some of these, but a normal EKG will definitely contain the P wave, the QRS complex, and the T wave. Now let's correspond this waveform with different activities in the heart. And the P wave represents atrial depolarization, the QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. Now note the direction of atrial repolarization as a vector. This corresponds to this positive deflection of this P wave. And just to be clear, this PQRST waveform is from a lead 2 in this image here. Now, as I mentioned earlier, because of this atrial direction, P wave is going to have a positive deflection. Now, the overall ventricular depolarization is going in this net direction. So this is represented by an overall positive QRS complex. Even though parts of this are going down, what we look at is the quote-unquote the integral, the area under the curve of this. So if we were to draw an imaginary line here and take the area above and below, the area above greatly exceeds, so this is seen as an overall positive deflection. Now just to note, the actual electrical activity of the heart is very complex. These vectors here and here are just simplifications. There's tons of vectors going this way and that way and all over, but these are just the net directions that we're portraying here. So this is an overall waveform that you need to be familiar with. The P wave is atrial depolarization, the QRS complex represents ventricular depolarization, and the T wave here represents ventricular repolarization. And this is really important to be comfortable with in order to analyze an EKG. So now, let's take a look at this image. This image overlays the hexaxial leads and the precordial leads on the same image. This is important because a 12-lead EKG lets us visualize electrical activity moving not only in the frontal plane, but also in the transverse plane. And this is really important because the heart exists as a 3D structure, so of course, the electrical activity will have to move in a 3D direction. It's important to know that the 12 leads of a 12-lead EKG are often categorized based on the location of the heart. So if we take a look at this diagram here, notice how all the leads, except for AVR, are classified as either septal, anterior, lateral, or inferior based on their location relative to the heart. So notice how leads 2, 3, and AVF are considered the inferior leads. Leads 1, AVL, V5, and V6 are the lateral leads. Leads V1 and V2 are septal, and V3, V4 are anterior. Now these classifications are particularly important for the analysis of myocardial infarctions, as they can give you information on where in the heart had the infarction. So it's a really, really important concept to be familiar with, is overall the classifications of these leads into these nice categories.
So now that we've talked about EKG leads, let's start talking about EKG analysis. Before I jump into the algorithm that I want to spend the video talking about, let's first review the basics of EKG paper. Note that the x-axis is always going to be time, and the y-axis is always going to be amplitude. Now each small box in the EKG represents 40 milliseconds of time going to the right and 0.1 millivolts of amplitude going up. Note that each big box is composed of a 5 by 5 of the small boxes. Therefore, it's going to represent 0.2 seconds or 200 milliseconds horizontally and 0.5 millivolts of amplitude going up. And note that this is already annotated in the image that I have on the screen here, so you can go back to it for your reference. Now let's talk about the basic EKG algorithm that I want to show y'all. Note that this is a basic algorithm and it's not an objective algorithm per se. There are many different strategies you can take to understanding EKGs. This is the one that's adapted from what we learned in class, and I find it particularly useful for beginners in learning how to analyze an EKG systematically. It can be very, very overwhelming, looking at all these lines that go up and down, and you're like, what's going on? So hopefully this provides you with a structure to analyze it without freaking out. So this algorithm is going to help you find out the rate, the rhythm, the axis, enlargement, ischemia/infarction, and the PR interval. Now in future videos, I'll probably go over other aspects, but this is a good basic framework to start with, and we'll talk about this today. Let's start by talking about how to determine the rate of an EKG. Note that the rate of the EKG will correspond to the patient's heart rate, or how many times their heart is beating per minute. There are two main methods to calculate the rate. There is the square counting method we have on the left, and there's a formula that we have on the right. Let's start by talking about the square counting method. To do this, we want to find an R wave on the EKG that lines up on one of those big, thick red lines that separates the big boxes that we talked about earlier. So in this case, we have an R wave on one of those thick lines represented in red. Now, there's going to be successive red lines that come after that, like this one and this one, etc. We want to label these with the following 6 numbers: 300, 150, 100, 75, 60, and then 50. Note that this image cut off, but you label them as 60 and 50. So you want to commit those 6 numbers to memory: 300, 150, 100, 75, 60, 50. So now what we do in the method is we start with our R wave here, and then we ask, where's the next R wave? The next R wave falls here, of course. And it's between the 75 line and the 100 line. What that means, it's the heart rate is between 75 and 100. Note that this method does not give you an exact number, but it gives you a good estimate. And if you're just trying to figure out if the patient is tachycardic, bradycardic, or in the normal range, this method is perfectly fine for a good estimate. So that's the square counting method. And we'll do a few examples in a little bit later just to reinforce this concept. Now let's look at the second method. It's this following equation. The rate equals 1500 divided by the RR interval length. The RR interval is just the distance between this R wave and this R wave. It's the interval between the R and the R. Now this length is measured in the number of these little small boxes we have here. So in this particular case, there is 5, 10, 15, let's say 19 small boxes between these two R waves. So the RR interval is going to be 19. So we do 1500 divided by 19 equals our rate. This method works because 1500 is the number of small little boxes that happen in a minute of EKG paper. So if a beat, let's say, took 1500 little boxes to complete, it would be 1500 over 1500 equals 1 beat per minute. Now that's obviously an exaggeration, but it reinforces the concept that this formula just comes from the basic math of an EKG paper. So these are the two methods. We'll practice them in a few examples now. So here we have our first example. If you want to pause it and work on yourself, you totally can. Otherwise, I'm going to go and talk about how to do it. So I've zoomed in on one lead. You can choose any lead you want. So let's start with finding an R wave that's on one of the thick lines. So let's start with this R wave over here. We're going to annotate the following 6 of those numbers that we memorized: 300, 150, 100, 75, 60, and 50. All right. Now we're going to start with this one and ask, where does the next R wave fall? Well, it falls between 75 and 100, right? So that means it's going to be between 75 and 100. and to also calculate the very exact heart rate by figuring out how many small little boxes are in our interval. And in this case, it's 5, 10, 15, around 17 or so. So it gives you 88, which is between 75 and 100. So now, let's take a look at our second example at determining the rate of an EKG. Again, I'll give you a minute to pause and do this example on your own if you wish. Let's start by doing method 1. Let's find our R wave in the thick line as denoted by my cursor here, and now let's label each respective thick line with the corresponding numbers. As you can see, the first R wave after the initial one happens between the line demarcated with 150 and with 300. Therefore, this EKG is between 150 and 300 beats per minute. Using method 2, I can calculate the 9 little boxes between the two R's and then do 100 or 1,500 divided by 9, giving us 167 beats per minute. So both these give us the similar or same answer. Now let's move on to our third example. Again, I'll give you a few seconds to pause in case you need to do this on your own, and then we'll move forward. So this isn't the best example to do method 1 with, actually, because this is very bradycardic. And as you can see, this first R wave after the initial one happens after we reach 50. So we can say for sure that this is slower than 50 beats per minute, but we can't give any more specificity beyond less than 50. So to give us a more precise answer, we'll have to use method 2. As you can see, there's 40 small boxes between the two R's, so 1500 divided by 40 gives us 38 beats per minute. So now that we've discussed rate, let's move on to the second part of our algorithm, rhythm. You can think of the rhythm as kind of where the initial electrical activity of the heart starts that sets it off beating. Now the rhythms can be broken up into 3 general categories: sinus, supraventricular, or ventricular. Sinus means that the rhythm starts at the SA node where it normally should. Supraventricular means that it starts somewhere pathologically above the ventricle, and that could be the atria or it could be the AV node. And ventricular means that the initial electrical activity starts in the ventricles themselves. Now, if the rhythm is sinus, there will be positive P waves in leads 1 and 2. And if they're not, the rhythm is not going to be sinus. And I want to add a huge caveat to this. This is a broad generalization. There are probably exceptions, but the general idea is that if you have normal P waves in leads 1 and 2, you probably have a sinus rhythm. That being said, I'm going to move on to the first example. So here we have an sample EKG. First, we're going to check leads 1 and 2 for the P waves. So I see lead 1 here. I see a P wave. I see a P wave. I see a P wave. P waves look good. I go to lead 2. I see a P wave. I see a P wave. I see a P wave. So both 1 and 2 have P waves. They seem normal. So this is a sinus rhythm. Now look at the second example. This looks a lot different. I see all these big waves that go up and down, right? These are the QRS complexes. But I don't see actually any distinct P waves per se. That's because there aren't really any distinct P waves in this. And because of that, this is not a sinus rhythm. This is actually a ventricular tachycardia. Now, I haven't gone into how to distinguish between supraventricular and ventricular once you've ruled out sinus yet. I'm saving that for another video. But for now, I just want you to get in the habit of being able to tell if an EKG is sinus or not, based on whether or not there are normal P waves in leads 1 and 2. So now, let's discuss how to determine the axis of the heart. The first method we're going to use is by analyzing the QRS complexes of leads 1 and leads 2. Now recall, the leads look at electrical activity coming directly at it, and since most vectors aren't going directly at it, it's only looking at the component vector directly in the direction of the lead. So let's look at lead 1, for example. Anywhere in this blue area here, there will be net positive deflection denoted on lead 1. That's because, let's say you're going in this direction, there's still a component vector going directly horizontally towards lead 1. However, when you're going straight up at 90 degrees, there's no horizontal component, so there's going to be no net deflection recorded. And I'm emphasizing the word net here, because if you look at this diagram over here, this part is a positive deflection, this part is a negative deflection, but the overall deflection of lead 1 is still positive. The net deflection is positive, and that's what's really, really important. So in this area here where my cursor is pointing right now, that'll yield a positive net deflection for lead 1, whereas this area over here will lead to a net negative deflection on lead 1. Now let's look at lead 2. Since lead 2 is looking at the 60-degree angle, anywhere between negative 30 and 150 going towards lead 2 will yield a positive QRS complex, and the other side of the circle will yield negative. Note that there's an overlap between the positive QRS of lead 2 and the positive QRS of lead 1. It's exactly between negative 30 degrees and 90 degrees. And that's really funny because that corresponds exactly to the normal QRS axis. What that means is that if both leads 1 and leads 2 have a positive QRS net, that means you have a normal axis. Let me repeat that again. If leads 1 and leads 2 have a net positive QRS, you have a normal QRS axis. And that's a really, really key point for this first method. Now, if one of them is deviated, if lead 1 is negative but lead 2 is positive, that'll give you a deviation. And the opposite result, if lead 1 is positive but lead 2 is negative, that'll also give you the opposite deviation. And we'll get into those examples a little later. The second way we can find the axis is by using the isoelectric lead method. Isoelectric lead just means that the QRS complex has a net deflection of 0. What that means is that the positive deflections going upwards and the negative deflections going downwards cancel out, and the net deflection is 0. This also might be seen as basically a flat line, but it could also be two pretty tall things going in the opposite directions that cancel out. So that is what an isoelectric lead is. So if we see that a lead is isoelectric, that means the electrical activity of the heart is going perpendicular to the isoelectric lead. So let's say, for example, that lead AVF right here is the isoelectric lead. Since that's in the direction of positive 90 degrees, that means the electrical activity of the heart is either going in 0 degrees towards lead 1 or 180 degrees away from lead 1. So now the question is, how do we know if it's 0 degrees or 180 degrees? Well, we can just look at lead 1, right? If it's positive, that means it's going directly towards lead 1, and we know that it's a normal axis. And if lead 1 is negative, we know it's 180 degrees, so it's a deviation. And we're going to go over this in 2 examples so we get some more practice. Let's take a look at our first example. Let's use our first method, analyzing leads 1 and 2. Lead 1's here, this QRS is positive. Lead 2 is here, this QRS is positive. Therefore, this has a normal axis. We can also use the isoelectric lead method to figure this out. So the isoelectric lead in this case is going to be lead AVL. As we can see here, this top part cancels out with this bottom part, so the net deflection is 0. So we know that lead AVL is the isoelectric lead, and based on what's perpendicular to it, the actual electric axis of the heart will either be positive 60 degrees or negative 120 degrees. Because lead 2 is exactly positive 60 degrees, we should check lead 2. Lead 2 is positive, therefore we know that the actual electrical activity is going at a positive 60 degree angle, therefore it's a normal axis. So now let's move on to the second example. Here's example 2. Now in this case, method 1 and method 2 will actually end up being the same thing, and I'll show you why. So let's start by finding lead 1. This QRS here is negative, right? And for lead 2 is actually isoelectric. So this actually turns into method 2 because lead 2 ends up being isoelectric. So now we know that lead 2 is isoelectric, we need to find the perpendicular angles to positive 60 degrees. That's going to be negative 30 or positive 120. And since lead 1 is negative, we know that it has to be positive 120, because we know that for lead 1, negative 30 would actually register as a positive deflection for lead 1. But since lead 1 is negative, we know the right answer has to be positive 120 degrees. So this categorizes in the right axis deviation section of the hexaxial diagram. Now, let's look at the types of enlargement and hypertrophy that you should be able to identify on an EKG. So there's 4 types we're going to talk about right now. Left ventricular hypertrophy, right ventricular hypertrophy, left atrial enlargement, and right atrial enlargement. And we're going to talk about each of these with their specific findings now. So for left ventricular hypertrophy, there's a wide variety of criteria that are used. The most common one is probably the Sokolov criteria. Basically, you measure the depth of the S wave in V1 and the height of the tallest R wave in either V5 or V6, and you add these two values together. If it's greater than 35 millimeters, it's considered LVH. And if you want to do the math right now, you can measure the depth of this S wave here and the height of this R wave here. Remember, each big box is around 5 or so. You can add them together, and that'll be greater than 35. So this is a case of left ventricular hypertrophy. Here we have right ventricular hypertrophy. So I don't think the criteria are quite as exact in terms of the numbers, but here are the 3 things you want to look for. Right axis deviation, a dominant R wave in V1, and a dominant S wave in V5 or V6. So for the right axis deviation, we see here we have a negative deflection of the QRS in lead 1 and an isoelectric lead 2. This is going to indicate that there's a right axis deviation, and if you need a refresher on that, you can go back to the previous part of the video where you talk about axis deviation to convince yourself. Now, in V1 here, we see that we have an R wave that's bigger than the S wave, and this is usually strange because in V1, generally speaking, the S wave is a lot larger than the R wave. So a dominant R wave definitely suggests right ventricular hypertrophy, and finally a more dominant S wave in V5 or V6. And here, these are kind of matched almost, and normally in V6, the R wave is a lot bigger than the S wave, so this suggests right ventricular hypertrophy. So now we have left atrial enlargement. You want to look for a bifid P wave in lead 2, and if you look at the P wave here in lead 2, you see it has like this part and this part, sort of like two little bumps on the P wave. That's what it means by bifid. Now you also want to look at the lead V1, and if you look at the P wave here in lead 1, you'll see it has two parts. It has an initial part that goes up and a second part that goes down. If that terminal part, the last part, is more dominant, that suggests left atrial enlargement. So if you see here, this bottom part is sort of more pronounced than this top part here, so that suggests left atrial enlargement in this case. Now normally, for V1, this is always going to be biphasic, but it'll be more evenly balanced. In this case, the terminal part is outweighing the previous part. Lastly, we have right atrial enlargement. So we want to look for a peaked P wave in lead 2. So let's look at lead 2 here. We see these P waves here are kind of like super tall and they have like a peak at the top. It's less rounded, more sharp. That's a peaked P wave, and that suggests right atrial enlargement. And secondly, we want to go back to V1. And in this case, compared to left, the initial portion of the P wave will be dominant. So if we see here, here's a biphasic P wave in lead V1. The initial portion is dominant, so this suggests right atrial enlargement. Now let's talk about ischemia and infarct. So I just want to point out the ST segment right here, as indicated on the image. The variations in this segment can suggest different types of ischemia and infarct. If you have a patient with unstable angina or an NSTEMI, you may see ST segment depression, whereas if they have a STEMI, you'll see ST segment elevation. And I'll show you what that looks like in the next slide. So here we have isolated QRS complexes and the things nearby. In this case, we have ST depression. So here's the QRS complex, and this ST segment is depressed compared to the rest of the baseline. You see this is here, that's here, and this is depressed compared to those two. So that's an ST depression. Whereas, if you look at ST elevation, you'll see the QRS here, and the QRS doesn't end here, then go up to the T. Right? The S ends there, and then you go up to the T. So that's an ST elevation. And that's suggestive of a STEMI. So the last part of our EKG algorithm is the PR interval. So as indicated on the diagram on the left, the PR interval spans from the start of the P wave up until the QRS complex, so all the area in between. And this is going to represent all of atrial depolarization and everything after that up until right before ventricular depolarization. Now, a normal PR interval should be between 120 to 200 milliseconds. This represents 3 to 5 small boxes on the EKG paper. However, a PR interval can be prolonged, and this is called AV block, and this can be caused by a wide variety of reasons, but it's important to be able to recognize this finding on an EKG strip. And in the next 2 slides, we're going to show 2 different examples where we calculate the PR interval length. So let's take a look at this EKG here and try to figure out how long the PR interval is. To start, I'm going to find the start of a P wave. So here's a P wave here, and I'm at the start of the P wave here. I'm now going to travel until right before the next QRS complex, which is right around here. So this is greater than 5 little boxes, so this is definitely greater than 200. It's around 8 to 9 boxes or so, depending on where you're drawing the lines. But this is definitely longer than 200, so this is definitely a prolonged PR interval. Now let's look at the second example. Let's find a P wave. Let's choose this one. So this is the start of the P wave, and it goes until here. This is around 3 to 4 boxes, so this is definitely within the normal range. So this is a normal PR interval. Alright, so thank you very much for watching. I appreciate your time. If you enjoyed the video, please like and subscribe. If you have any thoughts, please leave a comment below. This was meant to be a very basic intro to EKGs, providing you with a basic framework of things to think about. I'll be making more EKG-related videos in the future, going over more specifics. If you have any ideas on what you want, let me know. Thanks, and have a good day.